Good morning, everybody. I'm David Blumenthal. I'm president of the Commonwealth Fund, and it's my pleasure to co-host this event with Health Affairs, and Alan Weil, my colleague in that, is here today as well. I especially want to thank our speakers, Representatives Michael Burgess and Gene Green. So they are both from Texas, so maybe it's for being with us this morning. I can't think of any two individuals at this point in our history who are better able to shed light on the events that have been going on around us with respect to health care, the Affordable Care Act, the Repeal and Replace, the American Health Care Act, you name it. It's been front and center for these two gentlemen. I'll be turning over to Alan in just a moment to moderate the discussion, but before that I'd like to just say a couple of words about the Commonwealth Fund. The Commonwealth Fund is a New York-based philanthropy which is nonpartisan and produces objective research. Our mission is to create a high-performing health system, and that includes trying to make sure that everyone who needs it can get affordable health care in the United States. Much of our research assesses the experience of Americans with health care, and we have a number of particularly prominent activities in that regard. One is our biennial health insurance survey conducted every other year since 2003. And another is our Affordable Care Act tracking survey, which since 2013 has helped to determine whether how the law is affecting the American people and providers of care. Our international survey, which we've conducted since 1998, is unique in comparing how well U.S. health care compares to 10 other developed countries. And every 3 years we produce a report called Mirror Mirror, which assesses the comparative performance of 11 developed countries, including the United States. Another one of these will be coming out in about 2 weeks. We produce scorecards that track the performance of states, localities, and the nation as a whole in terms of healthcare delivery system performance, and we do work on the delivery system itself with a special focus on trying to improve care for the 5% of Americans who account for 50% of all healthcare spending. I want to say a word also about our involvement with journalism. We try to support and help journalists cover healthcare issues, and we have a number of programs in that regard. We support the Association of Healthcare Journalists reporting fellowships on health system performance. We also support the Solutions Journalism Network and the PBS NewsHour, which has been doing a series on new approaches to caring for the sickest patients among us with our support. And we support the Columbia Journalism Review blog covering the healthcare fight, which aims to inform reporting on the Affordable Care Act and the debate around repealing and replacing it. As I said, we're delighted to partner with Health Affairs on this briefing and a number of other important projects, and I'm going to turn the microphone over now to Alan.
Thank you, David. I'm Alan Weil, Editor-in-Chief of Health Affairs. Health Affairs is the leading health policy journal in the United States. In addition to our journal and a very active blog, we're thrilled to be able to host events like this with the support of the Commonwealth Fund. And as Dr. Blumenthal mentioned, the Commonwealth Fund Health Affairs relationship has many elements. This is just one of them. We, too, are nonpartisan, and we're pleased to be able to sponsor an event with these two congressmen representing, of course, both political parties in the midst of a very complicated and important discussion and debate over the future of health care. There's really no need for more substantive introduction, so all I will do at this point is introduce our two congressmen, and they'll make some remarks, and then this, of course, is an on-the-record press briefing, and we mostly want to field your questions. Congressman Michael Burgess represents the 26th District of Texas. He serves on the House Energy and Commerce Committee, where he's chairman of the House Energy and Commerce Subcommittee on Health. He's also on the Subcommittee on Oversight and Investigations and the Subcommittee on Digital Commerce and Consumer Protection. He's also a member of the Rules Committee. He's a medical doctor who received his MD from the University of Texas Medical School in Houston. Congressman Gene Green is from the 29th District of Texas. He's also a member of the House Energy and Commerce Committee and the ranking member for the Subcommittee on Health and serving on the Subcommittee on Energy, Subcommittee on Environment, and the Subcommittee on Digital Commerce and Consumer Protection. A lawyer who attended Bates College at the University of Houston. He served 27 years in the Texas House of Representatives and the Texas Senate. So I'm going to turn it over first to Congressman Burgess, and then we'll hear from Congressman Green, and then we'll open it up to all of you. Congressman.
Thanks, Alan. So I usually start out by saying, people must be looking at their programs. You got a Republican from Texas talking about health care. I wonder who canceled on Alan at the last minute. But this is important stuff. I appreciate you acknowledging the complexity and the difficulty of the questions that are surrounding this issue. I do want to point out, and I'm sure Congressman Green will agree, that there are a number of things that we're doing at the subcommittee level, and in fact at the full committee level yesterday, we just passed the user fee agreements for the Food and Drug Administration. The third time that has happened in my congressional experience. It is a 5-year authorization. It's different from the other authorizations or reauthorization bills we do in the United States House of Representatives, because if we don't do our work, we can't simply say the dog ate my homework and we'll give ourselves an IOU until the next time. We actually have to get the work done, because the dollars from the user fee agreements would stop flowing to the Food and Drug Administration, and that would depress them, and they would not be able to do their jobs, and no one wants that. So we did our work yesterday at 2 weeks ago we did it at the subcommittee level. Yesterday we did it at the full committee, and my anticipation is it will be on the floor of the House before too long. The Senate has had their committee markup, and I expect them to have a similar action, and we will get this done well in advance of the end of the fiscal year, which is September 30th, but it is important that it be delivered and delivered on time, or there are some negative consequences for doing that. On the Affordable Care Act, or the American Health Care Act, and I know this is on the record, but just between us, had I been in charge of nomenclature, I would have called it the Protecting Our Children's Future and Eye on the Horizon Act, but I didn't get to name it. So the American Health Care Act. And I just want to take you back a little bit. Obviously, we've had elections in this country in 2010, 2014, 2016, where arguably the Affordable Care Act was on the ballot and did not fare so well. In 2014, after the election where the Senate changed to Republican hands, there was a bill passed under reconciliation to repeal large portions of the Affordable Care Act. That bill passed the House, it passed the Senate, it came back to the House and was passed. In December of 2015, was sent to President Obama's desk, and he vetoed it. But the implication was that now the House and the Senate in Republican hands have tackled these problems that are replete through the Affordable Care Act, and they were willing to step up and take action on those. And if the White House were not the obstruction, that in fact that would progress forward. I would subscribe to the thesis then that is in fact what changed in the 2016 election. So of course something was going to be undertaken on the Affordable Care Act, and it was based upon the reconciliation bill that was passed in December of 2015 that was vetoed by President Obama. In fact, when I talked to my state counterparts during the month of December of this year, it was based upon what was in that reconciliation bill from 2015. Pay attention to what we did there. This may be what you are having to deal with at your state budgets and your state sessions. So I wanted to make it crystal clear what I thought the moving parts were. It changed somewhat in early January, and you had members as varied as from the House Freedom Caucus, who was quoted in the Morning Consult on January 11th, if you're taking notes, and said we had to replace as well as repeal the Affordable Care Act. You all had the President of the United States say that the repeal and replace should be done simultaneously, and many of you caught me off the floor. What is the definition of simultaneous? And I tried to draw that out for you. But nevertheless, there was a lot of discussion about replace in early January. We also had roundtables with the governors, who were up for the inauguration at first, and then a bipartisan roundtable that Kevin McCarthy convened, and listening to our governors around the country, they were asking for the flexibility, the constant search for waivers to try to make a system work that was not in fact working was something that was distressing to them, and they welcomed the fact that they were invited to the discussion. In fact, it was pointed out that they weren't invited to the discussion in 2009, and this was a refreshing change. We put together a bill based on 2015 reconciliation bill that did come through the Energy and Commerce Full Committee, and the markup went on for 28 hours. You may have read about it. It was in a lot of the papers. And I felt like we had a product that was very serviceable at the conclusion of that. Medicaid had been dealt with in the first reconciliation bill in 2015 to simply end the expansion in 2 years' time. We took a more nuanced view of that, recognizing that there were senators from Republican senators who were in states that had expanded Medicaid, and there needed to be some sensitivity. So the soft landing for the expanded Medicaid populations, allowing people to stay on for 2 years, and in fact indefinitely, if there are no changes in their status, was one of the compromises that we worked on the House side. I got a fair amount of criticism from more conservative members of the Republican conference, but nevertheless, that was the compromise that was worked out. A state like Texas that did not expand Medicaid would not be subject to withdrawal of the disproportionate share funds, which are scheduled to happen on October 1st of this year under current law. So compromises made on both sides, and again, I thought we had a good product. Unfortunately, it got pulled from the floor. Some additional changes were made. We'll see what the Senate does with those. It obviously eventually did pass, survived 3 CBO scoring exercises, and survived the bird bath, or at least the first bird bath, over in the Senate Budget Committee. And the chairman of the Senate Budget Committee pronounced this week that indeed it would be now heard by the Senate. And I welcome that. Are there changes that they can make? Sure, I suspect there are. Are there changes that I would accept? I suspect many of you will have questions about that this morning, and the answer is yes. As I said numerous times in televised appearances as we were coming to the vote on this, we'd taken a lot of criticism from our colleagues in the Senate that they were so much smarter than we were, and they would do such a much better job with this, that I welcomed their opportunity to move this forward. Now, in addition to whatever happens with the Senate with the American Health Care Act, we did our user fee agreements. We will have a hearing next week on the funding for the state children's health insurance program. We've got a number of other hearings teed up, one on the 340B program, because people have questions about that, and it's been 3 or 4 years since our committee has looked at that, something that's personally important to me. I'm trying to organize a hearing around maternal mortality in the country, and how has the opiate crisis impacted maternal mortality in the United States of America. But can I just tell you this from the standpoint of someone who spent a lot of years practicing medicine? When I get asked the question, with all of the turmoil surrounding the policy and payers, and it's got to be a tough time to be a doctor. And the answer is yes. But don't forget, we passed the Cures bill in December, and that was an energy and commerce product, and that was a bipartisan product. And my expectation is the delivery that Cures is going to have for drugs, devices, therapies in the future. This generation of doctors that is coming, that is in medical school and residency today, are going to have tools at their disposal that no generation of doctors has ever had to alleviate human suffering. So from the standpoint of when I talk to the young folks who are investing in their time and effort into training programs right now, the future is bright. Yeah, there's lots of bumps along the road in the policy side, but they're young, they've got a lot of time, they've got very fast computers, and I've got every amount of faith in them. Thank you.
Thank you. My name is Gene Green, and I'm also a member of the Energy and Commerce Committee, and Mike and I spend a lot of time together recently. Although at one of our more contentious hearings at the end, Mike leaned over to me and said, Can you imagine how two Texans got to be chair and ranking member of the health subcommittee? But obviously we come from different parts of the state. I have a district, very urban district in Houston, predominantly minority, 77% Mexican-American ancestry. The reason I do healthcare, and I do energy also, welcome to Texas, but the reason I do healthcare is because before the Affordable Care Act, I had one of the highest percentage in the country of people who worked who didn't get insurance with their employer. So our employer-based coverage was not successful, at least in low wealth areas, and so that's why the Affordable Care Act, it wasn't a bill that I wanted to have, because there's actually, those of you remember, it was a Senate bill, because political dynamics, the Democrats lost 60 votes when Senator Kennedy passed away in Massachusetts, and we ended up with the Senate version of the bill. The House bill didn't have Cadillac tax, it didn't have iPad, didn't have some of the things that are more controversial. And also, we didn't have the language that the Supreme Court allowed states to not to expand Medicaid. There are things I would do to fix the Affordable Care Act, and I think there are things that are not insurmountable. Although, as you know, for 7 years since 2010, we've had untold number of efforts to repeal it, and now the replacement, and I'm glad the leadership, the president said we're going to replace it, but as he said, health care is difficult, and how do you to replace it? One of the things I would do, it wasn't in our bill that we had a 27-hour markup on, although, by the way, Mike, you remember some of our cute amendments that we renamed y'all's bill that didn't pass, but I think we spent 5 hours just trying to argue over what we're going to name this, the Republican majority bill. But if I was going to fix the Affordable Care Act, I would have won the cost-sharing reduction payments. The Congress needed to deal with those. The President did it under his executive authority, but you have to be able to do that, and we would statutory allow it and give it some certainty, but also afford those so we could stabilize that kind of market where those cost sharings would come in. Of course, in our district, if Texas would have expanded Medicaid, 46,000 plus of my constituents would now have Medicaid coverage. 46,000 out of the district that has about 720,000. So I would have, if you took Medicaid in Texas, you would have taken the whole thing, and that way the expansion would have been there. I would change that to the way it was in the House bill that wouldn't have allowed states to cherry pick whether they want the expansion or not. I would create an option for people, particularly from 50 to 64 years old. If you look at the markets over the last few years, that's where a lot of the costs come in. As we get older, we go see the doctor a lot more. And there would be an option there that we could deal with that harder to insure. I would tighten the special enrollment periods. The intent was to try and get everyone who could sign up, and so they kept extending them. But the problem is people game the system. And if you're the young and invincibles, as they were called, they would say, "Oh, they're going to continue expanding. I'm not going to buy insurance yet." We should have made those hard dates for that, so people would know they have to sign up. I'd enforce the individual mandate more strenuously to make sure that those taxes, those fees, or those penalties were paid, so people would then go in and do it. These are not earth-shaking issues. That was the intent, I think, of the Affordable Care Act in 2009 and 10. It just didn't work out that way because, reality gets in the way of it. But that's what I would have done to expand Medicaid, make sure those payments and that's what's happening now because our companies are withdrawing from markets because they don't know if those subsidies are going to be there. And that could be fixed. But now we have the American Health Care Act, I think it's called, and although we have some cute names for it, but that's not going to help one of my constituents get more health care. And that's the problem I have with it. So, but I appreciate the Commonwealth doing this. I enjoy the conferences at the partnership between Alliance and Commonwealth, and I also appreciate the Health Affairs for partnering this morning because even though we have a lot more things going on today than anybody wants to know about. But healthcare is going to be there because it's going to be with us. And the good thing about Mike and I being co-chair and ranking member is that we don't have to have an interpreter to talk to each other. So.
Well, now it's time for you to ask questions. There's a lot of material to work from. We are webcasting this, so we need you to wait for a microphone, identify yourself, but please, what do you want to hear? We'll start with you here. We'll come up to the front. We'll go back here. The microphone's right behind you.
Yes, I was wondering what happened
Just
to the...
go ahead and identify yourself at the outset.
Sue Darcy from MedTech Insight. I write about medical devices and diagnostics. What happened with the diagnostic accuracy and, what was it, Innovation Act? I know that was raised earlier this year.
Yeah, it's still one of those things that'll be under our consideration. It was not included as part of the user fee agreements, but it's clearly still important to the subcommittee. It's important to members of the subcommittee, myself included. I may be in a little bit different place than some other members on the subcommittee, but we all want accuracy in our laboratory testing, our laboratory developed tests. Just speaking for myself and not for the committee, my concern was that because of the significant number of laboratory developed tests that are already present under CLIA, that if the Food and Drug Administration, the Office of Devices, undertook to approve all of those plus new ones that were coming, new tests that were coming online, that was a task that would be almost impossible to accomplish. And they were already behind with the work that they already had. So I was concerned about, I'm a believer in laboratory developed tests. I used them when I was in practice. They are a diagnostic adjuvant. They are not always the last word. You do need to keep your clinical judgment on track. You can't just let a laboratory test substitute for that. But at the same time, I did not want the development of those tests to be hindered by the changing the regulatory system from one administered by CLIA to one administered by the Food and Drug Administration.
I think what Mike said is correct. We're not quite to that level where we need to get there. Of course, this year, over the last 5 months, repealing the Affordable Care Act, but also I think the most serious thing was extend the user fees, and our subcommittee did what I think we were supposed to do. I'm proud of our work. We had legislative hearings, we had the industry, we had the FDA many times, and we worked on to make sure that we didn't want to be the first Congress in 20 years not to extend those fees and not to have that funding go to the FDA. And then we had a markup yesterday that was pertinent. And we did add some things to it, but again, we were only for those things that we actually had hearings on and had some testimony on. So we spent a lot of time on that, but I'd like to get to the lab developed test issue because I think that's something we might be able to work out, but we have had a lot of other things on our plate.
Summer for that?
They don't let me call hearings. I suggest to Mike, but
I don't know the precise answers to that. If you define summer as concluding on September 21st, when the sun crosses the meridian, yeah, it may be possible that we would. I don't think.
But not before August 1st.
I don't know that it's possible before the August recess.
Okay.
So we have a.
But I do think it's possible this Congress, which clearly goes until the end of calendar year 2018.
Okay.
Here in the front.
I'm Alex Ruoff with Bloomberg BNA. Dr. Burgess, I did want to pose the question you kind of posed to yourself when the Senate has been having a lot of wide discussion what they're doing with the AHCA, extending that glide path for Medicaid up to somewhere like 7 years, making some adjustments to the waiver program, boosting reinsurance. I'm kind of curious to ask, do you think are there any of these changes, at least in your mind, that the House won't accept? I mean, is there a sense in the, at least among House Republicans, that whatever the Senate comes up with is better? They're so smart and deliberate.
Yeah, they're so smart. They'll tell us, right? At this point, it would be way premature for me to say what would or would not be acceptable to other members of the House of Representatives. Clearly, I'm glad they've got it. I'm glad they're working on it. I think it's important work that needs to be done. They were as an important part of this puzzle as we were, and so we anxiously await their results. I'm sure they may even come up with, I think many of the parameters they're going to find are exactly the same that we had to work with, which were the same as the reconciliation bill that they did in 2015. So I think those guideposts are going to remain, but I also recognize that there are a lot of bright minds over there, and they may come up with some innovative strategies that hadn't occurred to us, and I'm certainly willing to listen to what they have to say. I think it's important that they get a product done. I think it's important that we evaluate whatever that product is, not just pass it, but evaluate it and make certain that it either conforms with what the House ideals were, or if there is departure, that they are acceptable departures, and then obviously it'll be up to the President as to whether or not he signs it.
You don't see a lot of vast changes being made. I'm sorry, if you don't expect to do those guideposts, you're not expecting it to be vastly different.
I don't, but I could be wrong on that. I accept the fact that I don't know everything. Unlike the Senate, I will admit that I don't know everything. And if they come up with an unbelievably insightful idea that just burns with a bright light, of course I'm going to look at it.
Congressman?
Well, I hope the Senate does much better than what we did. But I think we need to look at how they get to it. The President said he wanted to cover more people than the Affordable Care Act. And if you have that as your value, then I hope the Senate would look at ways we can do that. And that's something we could do on a bipartisan basis. Hopefully they'll do that in the Senate. Have a bipartisan basis, although, it'd be a reconciliation process and they don't need Democratic votes. But if they really want to do what I think is good for American health care, we need to make sure folks have access to health care, additional access instead of even what we did with the Affordable Care Act.
Okay, now I got to say something because, and Gene knows this, he's heard me rant on it before. When you passed the Affordable Care Act and you mandated that members of Congress would take it, and then you did a fancy trick that you didn't have to take it. And I said, that's not good enough. I'd better do what everyone in my district will do. So I bought an unsubsidized bronze plan in the Federal Fallback Exchange in the state of Texas. Most expensive insurance I've ever bought in my life. I had to buy it with after-tax dollars. It covered next to nothing. Someone asked me, well, or at least are your doctors on your plan? I said, I didn't look, because with a $6,800 deductible, I'm not going to the darn doctor. You'll have to carry me in feet first, and that's the way a lot of people feel. Now, contrary to the popular lore, I did reach out to my legislative liaison in the Obama administration on more than one occasion and said, look, this situation is tough on people back home. And I know that because I live in this and I hear from people all the time who feel that they're functionally uninsured. Now, Commonwealth Fund writes lofty papers about an activated patient. I believe in that too. I've had a high deductible health plan for 20 years since the Kennedy-Kasselbaum bill passed, and I was able to get a health savings account. I think there is a lot of merit to that type of system. But when I would ask my legislative liaison at the Obama administration and say, look, you guys have apparently embraced high deductibles, why don't we take the next step? And anybody who goes to healthcare.gov and says, I want to buy a bronze or silver plan, they are automatically, that is an HSA qualified plan by definition. They don't have to go out and search for one that can be difficult to find in your computer system. Let's also raise the amount that an individual can contribute to their HSA so that it at least matches the deductible. My limit on contribution was $3,400. My deductible $6,800. Clearly there's an arithmetic problem there, but it's easily solvable with the numbers presented. So why not do that? And then, wasn't in our committee's jurisdiction, but Again, I would stress, I was paying with after-tax dollars. Now, people in the employer-sponsored insurance, there is a tax break that employers get, and we've had a lot of discussions around that, but why not make that tax break available to the person buying in the individual market? And again, we're talking about a fairly narrow segment of the insurance buying population, but it is one thing to have coverage, it's another thing to get care, and if you don't go because there are economic barriers, I'm sorry, you're in the same place that you were before.
Well,
End of rant.
I didn't go home to Texas to buy my insurance, but I did buy it through the exchange here in Washington, D.C., and I probably would put my premiums I pay because we have to have physicians in Washington and physicians in Houston, Texas. So it's the most expensive insurance I've ever paid for. I should have just gone on Medicare. But be that as it may, I'm on the exchange here. And what Mike says is true, but for 7 years, 7 years now, we haven't had a chance to do some of those things. Although most of what
You had every chance in the world. I begged for us to
for the
do
last
something
7
on making
years.
every plan the bronze or silver level HSA compatible by definition.
Okay, the last
Pretty easy-
7 years,
pretty easy lift.
we could have done what every legislative body ever does. If you pass a law, whether it's in the Texas legislature or in Congress, you go back and revisit it after 2 years and see what we can do. That was never seriously taken. All we did was vote 50-something times to repeal it. We could have put together something like expanding the HSAs to cover that deductible, but that wasn't part of
No,
what
you could
we
not,
heard on the
because the
floor.
mindset of the administration at the time was, you must not harm a hair on the head of Obamacare. We are not going to tolerate it. And yet, at the same time, the president would make unilateral decisions. Let's just delay the employer mandate by, say, a year and a half on the 4th of July weekend. So, I mean, it was a frustrating environment. I'm sorry, I will not accept the fact that we would not work on that. I presented ideas to the administration on more than one occasion, got a nice smile and a handshake, and that was the end of that.
Well, I have to admit, I had disagreements with our administration also, but when you have the majority since 2010, if you really wanted to do that, there should have been a bill introduced. We could have had hearings on it and said, this is what we think. And there are a number of us across party lines who like working on those issues.
HR 35, you can still co-sponsor it. Not too late.
I'm going to try to get
That's a one-shot issue.
Going to try to get another question or two in, because I know you gentlemen have a time limit, but the woman back here.
Yeah, we got to go solve the problem of cybersecurity and electronic health records.
Hi, good morning, Katie Leslie, Dallas Morning News.
And I know who to blame. Oh my gosh. Okay. Now I got
Yep.
there's some
Good morning.
accountability now.
Hometown.
Well, I've asked both of you a little bit about this, so I'm going to just directly put you on the spot. Curious for both of you, your thoughts on the MacArthur Amendment and the impact of letting states pursue waivers to redefine what essential health benefits are for a state, what you think that could mean for Texans or Americans, what it could mean for average premiums, access to care, and then finally, if both of you believe that will remain in the Senate bill.
You want me to answer first? Okay. It's my turn to answer first. I think it's terrible. I served 20 years in the state legislature trying to do health care plan. If you've seen the mandated benefits list that most states have, it's just crazy. But we need to have, so folks know what kind of insurance they're getting, whether they're in Louisiana, Texas, or New York. And that's why the national plan. And so, that may pick up Republican votes, but it actually makes my vote harder because I don't want to have, 50 different plans and where certain states will cover certain things and in some states you don't. So that's not a vote winner on the Democratic side.
I think it remains to be seen. Clearly, it was not part of the bill that we passed out of the Energy and Commerce Committee. And I don't see that it was a serious omission as we passed the bill out of the Energy and Commerce Committee that we didn't have language like that. I actually supported our product continuously, even through those 4 weeks that it got pulled from the floor of the House. Ultimately, it was important to get the bill over to the Senate, and that's why I supported it the day that it came back up on the floor. Is the Senate likely to change that? I mean, I would not presuppose anything from the Senate. My admonition to people back home when they say, what do you think will happen in the Senate, If the vision is that you want the bill to get more conservative, that may not happen in the Senate, my experience. But I have no way no predictive ability to know that. Suffice it to say, I think we had a very good product as we came out of the Energy and Commerce Committee after that 28-hour markup. I was discouraged because it got the changes that were continued, but nevertheless, at the end of the term, I thought we had something that certainly deserved to get over to the Senate and see what they would do with it. If they like that concept, if they expand on that concept, we'll see what it looks like when it comes back. I suppose there is also the possibility that it would not survive over in the reconciliation challenges over in the Senate.
Let's try to get two more in if we can, right there, and then we'll.
Brianna Ely with Politico. I was just wondering if there's any appetite on Capitol Hill for a temporary fix to stabilize the insurance markets. We saw Anthem pulled out of Ohio earlier this week, and we've seen other insurers pull out in different states. So I was just wondering if there's any sort of talk on the side about trying to kind of close this gap in the meantime while you guys work out a health plan.
The answer is yes.
And what does it look like?
It's varied. You can obviously hear both sides of that discussion. I'm in a little bit difficult position as a member of the Rules Committee. I was one of the parties to the lawsuit against using the unappropriated dollars for the cost sharing reduction. Had the bill been drafted correctly in the first place, those dollars would never would have been required to take those dollars from the Treasury, because there would have been satisfactory funds collected from the insurance companies who were participating in the cost sharing reduction. That did not happen. So because of that error in creation of the law, now states are finding themselves in some difficulty. I think the president has, at this point, I think the fact that the payments continue to be made is an important point. I don't know that anyone's completely willing to do something different from where the lawsuit brought us, but the president has been willing to make the payments, and I would just take that at face value, and I think that's an important point.
We're in the minority, and sometimes I feel like I'm in a cave in a mushroom, because we don't hear any of that discussion until it's there. I would hope if we really want to pass legislation, you would bring in folks who do health care on both sides of the aisle and say, what can we do? Obviously, what Commonwealth and Alliance has been working on for many years, and it's worked in some cases. We have had that cross-party. I think the user fee is probably a good example of that.
So do we have a microphone?
Rich Daly, Healthcare Financial Management Magazine. At this point, obviously there's a lot of variables, a lot of things outside of even the House's control. What operative time frame are you both operating under that you expect there to be a resolution of the AHCA fight? And at this point, what percentage chance do you think it actually has, or some version of it, to be enacted and clear Congress?
If the timeline is indefinite, then I would say a 99.4% chance that something would be enacted. And I can't tell you the timeline, because you've heard all kinds of statements, from it's not happening this year to my own senator back in Dallas saying, Senator Cornyn saying it will be done by the 4th of July recess. So obviously both scenarios are possible, and the likelihood of success probably is directly proportional to the timeline that's available. But again, that's for us humble House members, that's largely unknowable.
I just hope that something comes back to the Senate I could vote for, and it would expand that access, which is one of the goals the president set.
I'm going to sneak a question in before you all run out the door. Congressman Burgess, you mentioned the Children's Health Insurance Program. It has a long bipartisan history, but it is running out of funds. What's the sense of whether that can move separately? Does it need to be part of the broader package?
I think all options are currently being looked at. Remember, the State Children's Health Insurance Program was a Republican bill that passed in 1996 before I got here. The Affordable Care Act did reauthorize the state children's health insurance program until the end of the fiscal year 2019, but it was only funded till the end of the fiscal year 2015 because everyone's going to have Obamacare and you wouldn't need children's health insurance. At least that's the argument that I remember from Pete Stark several years ago. I guess it turns out that that was non-operable also. In 2015, it was extended. The funding was extended for an additional 2 years. There was some back and forth as to whether that should be 2 years or 4 years. I would argue that with that funding, perhaps some good game as well, that we got rid of the SGR formula, so that was a reasonable thing to have happen. Is there something else that could also pass along with this interval of SCHIP funding? It is possible, but certainly there's also an argument that is made for let's just fund it for the last 2 years. You hear longer periods of time identified from, and again, I'm just going to speak personally, not as a member of the conference or the subcommittee. I think the funding ought to go to the end of the authorization and then the decision made as to whether or not the program is reauthorized and refunded into the future, and not continue funding for 5 years for a program that stops being authorized in 2019. I don't think that's a smart way to go.
Well, I would hope that we would extend it for 5 years, which is give or take a year. But both the community health centers and, like I said, it was last year. It was under the SGR, fixing the SGR. But we also extended our federally qualified health clinics for the 2 years with mandatory funding. That's always been a bipartisan issue. We have those up again this Congress, along with the CHIP program. But Mike's correct. We need to factor in what's going to happen with the Affordable Care Act, because, again, we thought that you would either be on Medicaid or you would be subsidized to have your children, but that's not what the market's done. So, but we want to make sure we have the CHIP program and expansion of federally qualified health centers. So,
May I just leave us with a thought from the New York Times editorial page? It said the president offers an important reform of Medicaid, proposing to control future spending by placing a cap on the amount of federal spending per enrollee and allowing states to place enrollees in managed care without going through the frustrating process of begging for Washington's approval. Editorial written February 7th, 1997, talking about the Clinton administration, talking about per capita caps, which was a Democratic idea in the 2 previous decades and one that was incorporated in the American Health Care Act. Thanks for being here.
well, we per capita tax or capping is not something. If you have a state that has a significant number of Medicaid, and in Texas we have probably one of the lowest Medicaid programs in the country, and so I would like to see some support and reform coming from the Fed, since in Texas the federal government spends 2/3 of the money for the state, and the state picks up 1/3, but the state doesn't even come up with 1/3. That's what they keep cutting physicians' reimbursements for. So Medicaid is a prominent federal program, and I think we ought to have the leadership in Washington.
Well, on that note, I know you have a hearing to get to. I want to thank both of you, Congressman Burgess, Congressman Green, David Blumenthal, the Commonwealth Fund. Thank you for making this event possible, and we're really thrilled you all could join us and offer your thoughts, and best of luck working through these thorny issues in the months ahead.